So I know I've met a few of you on the NMP forum before, but my name's Helen Harris. I'm a nurse consultant in palliative care at the Trust since May. I worked for a very long time in specialist palliative care before that, over in Calderdale and Huddersfield Trust, which is abroad in West Yorkshire, over the hill. So yeah, really good to see you. I'll maybe just say a little bit about the service. So the service that we have in the Trust is integrated. We've got people who predominantly work in community and those who predominantly work in hospital, but certainly myself and the medical consultant work across both. And I guess, obviously, all our patients that we see are, well, usually in the last year of life and often a lot less than that. But none of them are going to recover from what's wrong with them. That might well be very different for lots of you. But I would just highlight to you that 30% of hospital inpatients will be in the last year of life altogether. And while they were doing that study in Edinburgh, they found that 10% of all hospital inpatients at any one time would die in that admission. So I know you're not all working in hospital, but you don't really get serious medical input, I guess, unless you're really poorly. Lots of people will get quite a bit of input in the last year of life. Whether that's a good thing or not is sometimes debatable. So end of life is big business. Obviously, COVID's brought this into sharp relief, but certainly from the hospital side of things, people will often be in the last year of life if you're caring for them in hospital. Are you all hearing me okay? Great, good, I'm seeing now.
Helen, could I just mention to everyone, I'm more than happy for everyone to be on mute. What I would suggest is if you can, put your camera on. It's not, I think it's just within this forum that if we can try and keep our cameras on, irrespective of what's going on behind you, it's just nice for the presenter to know that they're speaking to people. And I know in this new virtual way, we often get sidetracked of the fact that, well, might be able to do emails or whatever. And I'm not suggesting that you guys are, but it's nice to see, for the presenter to be able to see faces as well, and you guys to interact with Helen. So yeah.
Thank you. Okay, so I'm going to try not to tell you everything I've ever learned in 45 minutes, but I've tried to pack quite a bit in, and I know you'll have access to these slides. So if you want to move on to the second slide, Faisal's going to be my glamorous assistant today. There we go. So as advertised, what we're going to try to get through is what we call the anticipatory medications that we use at end of life care, and how indeed to prescribe them properly. EOL, end of life, EOLC, end of life care. I'm going to talk a little bit about how to manage other illnesses that patients already have at the end of life. So probably when I first started in palliative care, people would have one thing wrong with them, the thing that was going to kill them. And that's really unusual now, because mostly people have got quite a suite of things that are wrong with them, many of which won't be what kills them, but certainly needs managing. So we're going to have a look at what we do with diabetes, Parkinson's, and people who are on steroids at end of life. So that might well get into a few more people's areas of practice. And then really importantly, we're going to have a bit of a talk about de-prescribing meds at end of life. I'm sure you will have all come across patients who are drowning in a sea of tablet boxes and packets and whatnot. Happily, one of the few happy things about being at the end of your life is you can probably ditch quite a lot of them. So it might be that you can support people to do that too. Okay, grand. So we'll move on there, Faisal. So the point of the anticipatory medications at end of life is to manage common symptoms. That's not to say that they're universal. So lots of patients will ask me and be very anxious about being in pain when they're dying. Actually, you're not forced to be in pain at all. One study suggested that 25% of cancer patients don't ever have any pain at all. And then there's kind of levels of severity after that. And obviously that varies outside of cancer. I should say that specialist palliative care isn't just about cancer patients at all. We very much see people dying of lots of other things as well. So the common symptoms at end of life do include pain, agitation. Terminal agitation is a sort of symptom all of its own. Sometimes you can work out a cause for it, but often you can't. And that absolutely needs managing. Breathlessness is common, and obviously again COVID, that's absolutely a thing as a feature of dying of COVID. Nausea is less common, and it often very much depends on what the underlying etiology is, but equally certainly for myself, I would rather do anything but be sick, never mind feel sick. So that's certainly a symptom I would very much want controlling. And kind of excess respiratory secretions. There's lots of different ways of saying that. You know, people sometimes refer to the death rattle, which even for me, I think that's a bit harsh. But you know, excess chest secretions, respiratory secretions. Yeah, so those are the common ones. So in order to deal with those, the medicines that we use in GM, and it does vary region by region, but will be morphine sulfate, which covers pain and breathlessness, midazolam, which covers agitation, also fitting, which I haven't talked about much, but we can do if you want to talk about that. Levomepromazine is an antiemetic. At bigger doses, we can also use it for agitation, but for the purposes of this, we're going to talk about its anti-nausea properties. And here we use glycopyrronium for trying to dry up respiratory secretions. Okay, so we can anticipate that these are the common symptoms. Therefore, we anticipate that if people get them, they're going to need some drugs to deal with them. So they're always prescribed in advance of need. I've often heard people say, "Oh, they don't need them yet." And I wonder where they've got their crystal ball from. You can be too late with these. You can be, I suppose you could be too early and they expire or something, but I'd much rather that than somebody be a day without some painkiller. So yeah, the clues in the question: anticipate, do it before you need it. And although they're not all, they won't all say, I don't think any of them say on the vial that they're licensed for subcut use. They are all used subcut and have been for a very long time in palliative care, and it's absolutely fine to do that, even though when you get the vial it'll say IV, IM, or whatever, but it probably won't say subcut, but don't panic, it's fine. Okay, thank you, Faisal. Okay, so we're just going to have a little look at the actual drugs themselves. So morphine, I'm sure this isn't going to be news to you, but you can remind yourself. Morphine sulfate, so it does act centrally and peripherally on all four opioid receptors, but mostly the new ones. The opioid receptors control the release of neurotransmitters. So basically, opioids work by stopping the bit that hurts, telling your brain that it hurts, if that makes sense. So it stops that pathway between the bit that hurts and your brain knowing that it hurts. Okay, so we use morphine as your kind of standard, both orally and injectably. So we're talking about injectables. Obviously, patients might be on oral morphine for pain or breathlessness or whatever, but we're talking about subcut versions to manage, because obviously approaching end of life, often patients aren't awake enough to swallow or are vomiting or something like that. So morphine's first line. Important to know what the renal function is. In GM, the guidance is if their EGFR, so the estimated glomerular filtration rate, is over 30, it's okay to go with morphine. Different areas have slightly different cutoff points. So because morphine has active metabolites, which also need clearing by the body, if you are struggling for your kidneys to do that, you've kind of got two lots of drug to clear, and it will accumulate if the EGFR is low. So that's relevant because we've got an alternative. When I started in palliative care, we didn't have an alternative, so we just used less morphine, and it just lasted a bit longer. But we've got an alternative, and that's oxycodone. So oxycodone is like a synthetic kind of man-made morphine, if you like. No poppies are involved in the making of oxycodone, and it is more potent than morphine, but it's much more bioavailable, far fewer active metabolites. It will accumulate if the EGFR is bad enough, but it's much safer. So we would go with oxycodone if the renal function was poor. Obviously, we've talked about how it works in terms of pain, but there's lots of evidence for morphine's use in breathlessness as well. So the patients I'm seeing on the COVID wards at the moment will often require some or a lot, but often subcut morphine because of their raised respiratory rate, raised respiratory effort, and feeling of breathlessness. And the evidence is there for morphine or oxycodone, just whichever one's relevant for their renal function. Is that okay? We all good? Good. I can see Zena nodding. Okay, thanks, Faisal. So side effects. We know about, they're mostly relevant at the end of life, but you can get patients who will be nauseated and or vomit with morphine. They can feel woozy. It's going to get constipated. That's much more important further upstream than right at the end of life. Dry mouth, really universal, really. You can get sweating, urinary retention, and itch. It mostly isn't an issue right at the end of life, but do watch out for nausea. If the patient's awake enough and they're very, very symptomatic, I will always have a conversation about them. We can start some medicines, we can help your pain, your breathlessness, whatever. You might feel a bit more woozy, you might feel a bit more sleepy. Is that okay? They always say yes, well, almost always say yes, but it's worth just having that conversation. It's often worth having that conversation if you can with the relatives there as well, so we're all on the same page and they're not going away saying, oh, that Helen Harris gave him a load of drugs and then he went to sleep and that was that. It's worth kind of just being really honest about things, really. Dry mouth's really, really common, and even at end of life, I don't think I've ever seen a patient at the end of life who didn't have a dry mouth without some sort of intervention to reverse that. There is a slide a bit later on about that. Urinary retention is important as well. Obviously, we don't want somebody being really full of urine, really agitated, bursting for a pee that they can't do. We'd need to know that, won't we, and to catheterise if that was the case. More important is to look for signs of over-opiation. It's not that common unless somebody's gone for a really crazy dose or worked it out all really, really wrong. But important to always bear in mind. So pinpoint pupils is an indicator. More reliable is those myoclonic jerks, where they're just kind of still and then the kind of their arm goes or the leg goes. If that's happening, then that needs addressing. And it might be that the renal function's dropped. They might have been on an okay dose and the kidneys have gone off. And obviously respiratory depression. To be fair, I'm mostly trying to get respiratory rates down from the 30s and 40s to something more comfortable and less exhausting. But obviously if it's kind of going, below 10, that might require some intervention unless they're literally taking the last breath. Okay, thanks, Faisal. Oh gosh, more morphine. Right, yes. So how to prescribe it properly. So if they're opioid naive, the sort of standard starting dose would be a range of 2.5 to 5 milligrams subcut PRN. And the current guidance from GM, which is, Faisal's actually going to share this with you. The guidance was updated in November, was about to be kind of circulated, and then COVID hit. But the GM guidance for palliative care, pain and symptom control was updated. So we've just kind of launched that quite recently, really. You might be used to seeing morphine prescribed 4-hourly. I'm used to seeing it prescribed 1 hourly in end-of-life care, because sometimes you give a dose and they need actually a bigger dose. But anyway, it's 2 hourly here, unless somebody's made a clinical decision to do it differently. If they're already on opioids, then the PRN dose is 1/6 of the total daily dose, bearing in mind that subcut's twice as potent as orally. So if your patient was on 30 BD of Zomorph, they lose their oral route because they're dying. So that equates to 60 daily of oral morphine, which equates to 30 milligrams a day in a syringe driver, a continuous subcutaneous infusion. Does that make sense? So add it all up to get the total daily oral dose, and then divide by 2 to get it to the subcut dose for the day. Okay, and then in that situation, you've got your 30 in a driver. You're going to go with 1/6 of that to get your PRN dose, and 1/6 of 30 is 5. Okay, so if you've got somebody who's been on a big dose of Zomorph and they get onto a driver and they've got 2.5 PRN, it's probably not going to hit the sides. So it is important to always check that the PRN dose is commensurate with the daily dose. And that's the same for Oromorph as well, but obviously even more important at this stage. Okay, thanks, Faisal. Okay, so move on to midazolam. This is just the best drug ever, and I say that without ever having taken any, but certainly I've administered it and prescribed it a lot. I don't know what they did before midazolam. It's a benzodiazepine and a GABA mimetic. So GABA is the inhibitory neurotransmitter in the nervous system. So again, it works like the chemical that stops neurotransmission. So it stops the bit of your body that's hurting telling your brain that it hurts. It's a kind of buy one get one free, or buy one get a number free, really. Brilliant for agitation and restlessness. It's good for muscle relaxation. So if people have got pain from kind of really tensed up muscles, that can be useful. You can use it as a replacement anti-seizure medication as well. So patients who are maintained on antiepileptics but then who can't take them at the end of life, we will usually use midazolam to prevent seizures. It is amnesiac, so it's really nice to use if somebody's had a really distressing pain episode or been really distressed with the breathing. A little dose of it along with a painkiller is really good, because they will often have forgotten about that episode and the distress that it caused, so that's quite helpful. And obviously it helps with anxiety as well. So really, really good in combo with opioids. Please don't be scared about using the two things together, opioids and midazolam. I often tell this, tell a story about a senior nurse that I worked with on an MAU, not here, who said, oh, I've got this patient, he's really agitated and he's in pain. And I said, I'm really busy, I'm just doing this. Just get him some morphine and midazolam, I'll be right with you. And she went, oh, what, both of them? Said, yeah, just 2.5 of each. What, together? Yeah. At the same time, yes, I'll come with you. So anyway, he was absolutely beautiful after 2.5 of each. Didn't die of having 2.5 of each. You know, you're really going to have to work hard to kill somebody with 2 vials of those things. It's cool. You'll just get somebody really nice and comfy. Okay, thanks, Faisal. So side effects for midazolam, obviously drowsiness, unsurprisingly. Oops. Just back one, Faisal, that's it. And forward, stop there. Okay, obviously drowsiness, and this is often, again, like I say, when you'd have a conversation, say, I can give you something for this horrible breathlessness, you're going to be a bit more drowsy, but you're going to be rousable, is that okay? And they say, God, yeah, just do anything, I'd much rather be asleep. Interestingly, you can get paradoxical agitation and aggression, usually at higher doses and not that frequently, but you can do. So if you're kind of getting up in the doses of midazolam, you're probably going to want to be adding in something in addition. Speak to us about it would be the key message. It can accumulate in renal impairment. There are active metabolites. So if the renal function is really dreadful, you might want to use half the dose of the dose you normally think to use. But to be honest, I would rarely prescribe less than 10 of midazolam in a syringe driver. I might have done that 3 times in 20 years, less than 10. Okay, thanks, Faisal. Was there some things in the chat that I need to take notes of? No, okay, good. So the dose, happily, is the same as a starter for 10 kind of thing, is the same as morphine, so 2.5 to 5 subcup PRN, and it is hourly. So it's got a really short half-life as midazolam. It'll work dead quick, maybe 10-15 minutes, you'll start and see a response, but it will be out of the system within an hour or 2. So don't panic if they've had some and then they need some more. It's really fine, and that's why it's really important to get it in a driver if that is what they're needing, because it will come out of the system fairly quickly. So in terms of syringe drivers, as an anxiolytic dose, 10 a day in a driver would do the job. You'll be able to rest, people will be feeling a bit more calm, but they'll be rousable, they can eat and drink. If you're completely knocked out sideways with 10 of midazolam in a driver, you would definitely die in anyway, I would suggest. Seizure control, there are some nuances around this, and there's much more guidance in the GM guidelines, but kind of 10 to 20 or potentially more. Again, please speak to us if you're in a situation where you're needing to replace or you need to replace and they're not actually responding to the dose you've given them. And agitation, sort of up to 60 or 80 you can use, but like I say, you're going to want to be thinking about adding in different types of sedatives if agitation remains a problem after you've started to escalate, maybe past about 30-40. And again, speak to us if the obvious things aren't working. Okay, is that all right? Making sense? Yeah. Okay, thanks, Faisal. So Levo used to be called Nozinan, and that was a bit easy to say. Anyway, levomepromazine, all the letters. So it's a phenothiazide antipsychotic, but with lots of antipsychotics, they've got antiemetic properties, and obviously we're using lower doses than we'd be using as an antipsychotics. They would use them at bigger doses. So this is the broadest spectrum antiemetic that we've got. It hits the dopamine, serotonin, alpha 1 and 2 adrenergic receptors, and histamine, and it's antimuscarinic, so it kind of covers everything. So I suppose the theory is that if they're going to be nauseated at the end of life, we're probably not going to be able to work out necessarily quite why, so we'll just try and hit everything. The only thing it doesn't hit is it's not a prokinetic. So we use it first line as an antiemetic at end of life, not necessarily all the time for everybody who's in the last year of life. You see what I mean? So that end of life bit. We can also use it for agitation. So it might be that they're getting up with the midazolam doses, and it might be that levo's added as a second sedative. Anyway, it's there as the antiemetic for end of life. If that makes sense. Okay, thanks, Faisal. So I have to be a little bit careful with it. It can exacerbate Parkinson type symptoms and can cause extrapyramidal side effects, as can actually quite a few antiemetics, haloperidol, metoclopramide. So it's a bit less bad than haloperidol as an antiemetic that will do this and make Parkinsonism worse. But at end of life, it's kind of less of an issue than further upstream, obviously. It will also lower the seizure threshold. So if you've got somebody who's epileptic, that's potentially an issue just to kind of consider. But yeah, it's kind of the best thing we've got, really. So the dose, it used to be 6.25 PRN. In the new guidance, it's 5. So it's a fifth of a vial. They come in 25 milligrams in. It's either 1 or 2 mils, I can't just remember. So it's a fifth of that vial rather than a quarter. Yeah. So in the syringe driver, you can give between 5 and 25 for nausea. we won't go into what dosage you can give for levo in terms of sedative, because that gets into lots of big numbers and we'd probably be involved. If it was literally just that they needed levo, I wouldn't put it in a driver. It's got a really long half-life. You can give a once daily dose. So if that's all that they're needing, I would just give a once daily dose and reserve that machine for somebody who actually needed a driver. 10 to a penny, they'll be needing something else as well. And obviously it can go in the syringe driver with your morphine, your midazolam, whatever else they're needing. If you use more than 25 milligrams, you're likely to get some sedation. Now you might want that to happen, and that's fine. Like buy one, get one free. But you know, be mindful that if they're alert and awake but nauseated, if you're getting up to 25, you might want to think about a different tactic other than sending them to sleep. Okay. So I'm very mindful, I'm giving you a lot of information here. You might need to go back and read it all again. So glycopyrronium is the fourth one for excess chest secretions. It's an antimuscarinic. It's got equal efficacy to hyoscine hydrobromide and butyl bromide in terms of addressing that symptom. The key thing is to get in there quickly. Whatever drug you're using, and in GM it's glycopyrronium, is to get in quickly. So if you've got a really good going, rattly, full of secretions, chest going on, you're probably not going to change it by starting glycopyrronium. If at the first hint of it, you get in there with the PRN dose and get a driver set up, you've got a much better chance of getting on top of it. We can also use it for as like an antispasmodic. So it's a smooth muscle relaxant. So it's good for kind of colicky pain as well, which sometimes people can have, you know, that tummy ache pain, or for bladder spasm as well. So it can be useful for that too. Okay, thanks, Faisal. Yeah, so you can get all your antimuscarinic side effects there. Lots, you know, it dries everything up actually. So the dry mouth you've already got with your morphine, you're going to get drier, and dry eyes, dry everything. And again, most of it's not massively relevant in the last few days of life, but dry mouth absolutely is, and like I say, we'll come on to that. So the dose for glycopyrronium is 200 micrograms mcg subcut, and they say sort of 6 hourly. I don't know what damage you could possibly do by giving it earlier than 6 hourly, but there we go. And we don't have to adjust for renal impairments. Max dose is 1200 micrograms in a day, and in a driver would usually probably start at 600 up to 1200 micrograms. But yeah, the key thing is to get in there quickly, really. Okay, thank you, Faisal. So mouth care, I've been banging on about this. I hope to be sponsored by some sort of oral care company. Absolutely essential, absolutely essential. Anything worse than having a dry mouth, you know, that you've been running, or that you're giving a speech you don't want to give and you're nervous. It's really horrible, isn't it? If you fall asleep with your mouth open, it takes minutes, doesn't it, before it's completely dry and you can barely even move your tongue. So our poor patients who are not conscious or minimally conscious, mouth wide open, breathing away, or, you know, 15 litres of oxygen blasting into their nose and mouth, they're going to have a dry mouth. It's going to feel horrible, and that's what makes you feel thirsty. So first thing, and I know it's teaching my granny to suck eggs, but it's to actually clean the mouth. Small soft toothbrush with a little bit of toothpaste is how everybody I know cleans their teeth and mouth, and it's no different at the end of life. There's nothing magic about pink tablets in water, just water and some toothpaste is how we clean it. That will still leave it a bit dry, but it needs to be cleaned before we start moisturising it. Water into a dry mouth, lovely, feels lovely. Swallow, evaporates, and it's gone. Back to square one. So unless you're literally going to stay there all the time doing the mouth care, we're going to want something that's going to last a bit longer to let you go and see to the next patient. So there's various products on the market. It seems to be Biotine oral balance gel that's what we tend to use here. There's Bio Extra, there's different ones. I'm not a massive fan of the squirty saliva things. That just makes me want to puke even thinking about it. But some gel, good stuff you add. A little bit, you can put it on the lips instead of the mouth. Just a gloved finger all the way around, and it will last for a bit and it will survive a few swallows. So big fan of that. It's kind of my 5th anticipatory drug, if you like, but I would always write it up on the regular side of the chart in hospital. And if you're at home in community, you're going to be teaching Beryl how to do that for Barry, and families will often be very happy to take part in that care. Okay, obviously if they've got thrush, let's see if we can treat that as well, by the way, in the mouth. So moving on to the second thing that we said that we'd cover today. It's about what to do with all those other comorbidities that people like to collect nowadays, like football stickers. So diabetes, obviously super common, and there's often a bit of a query about what do we do at end of life. So this is what we do at end of life. Type 2 diabetics on oral meds, we can stop those oral hypoglycemics, which is handy because they probably won't be swallowing them anyway. Basically, they will have some insulin production, as well as eating and drinking probably very little, because it's normal to slow down your eating and drinking, to stop eating and drinking before you die. Okay, well, unless it's a sudden death, obviously, which is not what we're talking about. So we only need to check the blood sugar if they're symptomatic, although that might be quite tricky to see what the symptoms might be. But if abdo pain, nausea, vomiting, or a fruit type smell to the breath, that might be a trigger to just check the blood sugar there. Okay, so that's probably the biggest group, isn't it? And they're fairly simple to deal with. Okay, thanks, Faisal. If they're type 2 diabetics on insulin, we need to try and reduce the insulin with an aim to stop. Checking the blood sugar only if symptomatic, and treating it if the blood glucose is only over 20 millimoles. So that's as in reducing the insulin in line with their reduced oral intake, really. So it just takes a bit of a balancing act. I would also always point to the third point there, which is to consult biting oral gel, I believe is okay with oxygen therapy, Julie, yes. Yeah, it's the oil-based stuff that there's some debate over whether there's an issue with oxygen at all, to be fair, but yeah, oral gels are okay. So type 1 diabetics on insulin, they've got no insulin production of their own at all, so they need to continue on the daily long-acting insulin to prevent ketoacidosis. The short-acting stuff you don't need. We're aiming for a blood glucose of about 10 to 15, and we can measure it less rigidly and less strictly. I am not an expert in diabetes, and I would always advise you to consult the specialist diabetes team if there's any uncertainty around that, and or us if it's about this kind of basic advice. I mean, for example, I wouldn't even know which one the long-acting insulin was. I would have to look that up or ask somebody. But those are the principles of it. And somebody was just asking about how quickly you'd reduce. I think that would, hi Verna, I think that will be around what the blood sugars were like and what their oral intake was like. So unhelpfully, the answer is it depends on the patient, really. Yeah. Okay. So that you've got everything I know about diabetes there, and a point to somebody who knows a lot more than I do. So steroids. Sometimes people be on steroids and they don't need to continue on them, but sometimes they're on them and it really is helpful to their palliative management. So patients who spring to mind would be patients who are taking steroids to control the edema around their brain metastases or brain tumour. They might have metastatic core compression, and that's helping to manage their pain potentially and or functioning. They might be on steroids for superior vena cava obstruction, SVCO, where the superior vena cava is obstructed by usually a lung tumour, or for general pain control. So you need to know why they're on it and has it been helpful, and therefore do we need to continue it. So if people have been taking stuff orally, steroids orally, and they have been very helpful, and we need to continue them to maintain their symptom control, we can continue it by subcut injection. I would always give it in the morning, which is also when I would prescribe oral steroids, because giving them later in the day can affect sleep at night and cause insomnia. So the conversion is on the next slide, thank you. Slightly tricky. There's two different formulations of injectable steroids. We generally use the 3.3 milligrams in a ml formulation, not to be confused with 3.8. I mean, who makes these numbers up? I have no idea. But so using the 3.3, this is the conversion. So if they were on 8 of oral dexamethasone in a day, that will convert to 6.6 milligrams of subcut dexamethasone, which is 2 mils worth, which is about as much as volume as I'd want to give in a subcut injection. Okay, I mean, you could always split the dose morning and lunch, but generally it's best just get it out of the way in the morning. If you're in any doubt, you can speak to your local friendly pharmacist or palliative care team person. Yeah, does that make sense? Just if it's been really helpful, we're going to want to continue it. If it's not, we might well stop it. Those are the conversions, so you've got those there. And then Parkinson's disease. So we've got an ageing population. I'm sure the older you are, the more likely it's to develop neurological things like Parkinson's. So certainly that's something I've seen more of as I've gone along in all the years I've done this. So patients with Parkinson's need lifelong dopamine replacement therapy to avoid rigidity, slow movements, tremor and pain. So you'll see patients with those classic Parkinson's symptoms. So having their dopamine replaced means that they also need to avoid dopamine antagonists. So don't want to stop the dopamine doing its job. So sadly, some dopamine antagonists are quite helpful. So antipsychotics, metoclopramide, talked about haloperidol and levo. So that's one consideration. The other consideration is to make sure that they still get their dopamine replacement even if they can't take it orally. So once upon a time, I think people had nasogastric tubes passed, even at end of life, to give them their Parkinson's meds. Thankfully, we don't need to put people through that anymore because we've got these retigotine patches, which we can just, they go transdermally. So, yeah, next slide, please, Faisal. The guidance around this is quite complicated, and that's why I've put that link to Parkinson's disease med calculator. So it depends what regimen they've been on before as to how much of a patch you give. It's not a perfect replacement. It depends what different meds they've been on, but that's where you can work it out. You need to know exactly what they were on orally, and PD MedCalc will work out the rest of it with you. The patches themselves are changed daily at the same time, and you would you would rotate skin sites. So just in terms of local irritation, maximum dose is about 8 milligrams a day in early stage Parkinson's disease, going up to about 16 a day at end stage Parkinson's disease. You can increase the dose of the patch about every 3 days in 2 milligram increments if necessary. But hopefully, if you can, like, they're starting to get a bit dodgy with the swallow, much better to get them changed, get them steady on the patch. And if they have days when they can take stuff, well, they can have an ice cream instead, can't they? Rather than be kind of hit and miss, because obviously the Parkinson's meds are important to have at the right times. And if you're missing them or they're delayed, they are going to start getting symptoms. So better to just nail it with a patch, I would say, in that circumstance. Okay, let's move on. I'm nearly on time. This is really good for me and unusual. So pain patches, generally, so people might have butrans patches, fentanyl patches. Yeah, they're probably the common ones. Yeah, buprenorphine and fentanyl. And then are getting into the last few days of life. Might have been nicely managed on the patch for the pain, and then they get into the last few days of life. Key message is leave them on the patch. Change the patch as usual, every 3 days, every week, or however long it is that patch should be changed. Carry on with it as normal. And the reason for that is that patches take ages to get up to speed in the system, and it takes ages to come out of the system too if you take them off. So it's impossible to calculate what's going on in those days after you might have taken a patch off. There might be at nearly full dose, there might be at nothing, there might be at somewhere in between. You've no idea. So leave the beggar on, carry on with it. And then if they need additional analgesia, don't increase the dose of the patch because that takes ages to take effect, but add with PRN subcut medicines or a syringe driver. What you do need to do though is to make sure that when you are working out the PRN dose, you've incorporated the dose of the patch and the dose of the syringe driver together, and that the nurses or the family or whoever it is know that there's a patch and a driver. Yeah. Because if you don't know there's a patch and you're looking at a syringe driver and you're wondering why there's this massive PRN dose, that can be quite scary. Or that you're merrily going along and then you realise there's a patch that should have been changed yesterday. So it is a little bit, can potentially be a bit confusing, just needs to be really clear documentation. But include them both in the calculation around the PRN dose. I see a lot of times when patients are approaching the end of life, they've got some pain, they think, oh, we'll start them on a patch, that'll sort the patch out. You haven't got time. You really haven't got time, and it's very hard to adjust that dose. With a syringe driver, you can take it off and it'll be out of the system in 4 hours. You can adjust it, the change will have happened within 4 hours. We haven't got that luxury of time at end of life, so you haven't got time of days to be messing about with a patch. So if it's already on, leave it, but don't start one new. Okay? Super, thank you. And deprescribing. So yeah, all these poor patients with multiple comorbidities get started on medicines with the best will in the world, and I'm sure our pharmacy colleagues will know all about this more than me. Obviously, we don't, prescribing ever, but especially end of life, just needs a bit of thought. I never want to see somebody just gaily crossing off everything without looking at what's there, or leaving everything on without looking at what's there. It just needs a bit of intelligence. So essential stuff: analgesics if they're in pain, anti-epileptics if they're fitting, sedatives if they're agitated, sometimes steroids, which we've talked about. So those are things that you really wouldn't want to be stopping, or you'd want to be replacing. Yeah. There are some absolutely non-essentials at the end of life, so last few days / hours. We don't need to worry about laxatives at this point, antidepressants, statins definitely not, vitamins. We can absolutely stop anticoagulants. I would stop anticoagulants at the point that we're saying they're in the last few days of life, probably not before, because actually dying of a PE is not usually very quick and can be quite unpleasant. No worries, Keith. Inhalers they're not going to be able to manage. Iron, what's that other thing that it says there? Antihypertensives, no. So there's lots that can be very safely stopped, but just give a bit of thought to why they're on it and why they might need it and why they might not need it. And then there's some in the middle, so we can consider stopping diuretics. Depends. We can consider stopping steroids, which we talked about, hormones, digoxin. We can think about, they might well not need antibiotics, but they might. Depends if it's keeping some pain inflammation at bay. Nitrates, again, you know, it's going to be an individual patient kind of consideration, isn't it? Patients will deprescribe for themselves when they stop taking stuff anyway by mouth, but we need to think about, well, actually, what do they need to be comfy? And that's always the thing in end-of-life care. What are we doing? Why are we doing it? Is it actually aiding their palliation? You know, because if it makes them feel less rubbish, then fantastic, let's carry on. If it's just another blessed tablet to take, not so much a fan.